Right, so this is the November 2021 MEC Minute, and this month we're going to talk about trauma triage. And this is a new thing for us in that Dr. Dizon is going to join us in this conversation. Dr. Dizon is our Associate Medical Director for Trauma. The interesting part about this conversation is our conversation is being recorded asynchronously. I'm going to start the conversation, record the show, try to be Spartan in my words, and then have Dr. Dizon add his comments to what I have to say. So this is an experiment for us in many ways.
Thanks, Dr. Zeeb. I appreciate the invite and look forward to participating in more of these podcast productions in the future. I also wanted to mention that Dr. Daniel Hall has joined us at Mount Carmel East. He is a graduate of the Mount Carmel General Surgery Residency Program, and afterwards completed his fellowship training in trauma and surgical critical care in the highly acclaimed trauma program of Tampa General. We look forward to him joining future conversations with us as well.
So let's talk about trauma triage, and we're talking specific to Ohio. So in Ohio, we have trauma triage rules that are part of Ohio Revised Code, and it can be amended from time to time via administrative rule changes. That is a laborious process, whether you're talking about the legislature making changes or the Division of EMS and the Trauma Committee making changes. So it takes time. This is the only area in terms of what we do for medical care in the field that is specifically legislated and to which we are held. So we're going to talk about these rules, and I think it's important that you understand them. And toward the end of the conversation, we're going to have a discussion about trauma centers and what the designation means to us and to our patients. So that'll be a couple slides, and I'm really looking forward to Dr. Dizon throwing in his comments to that section of our conversation. So talking about trauma triage, trauma triage rules really start with the definition of what is trauma or traumatic injury. And there are two requirements that have to be met. The first requirement is the patient has suffered an event that represents a significant risk of either loss of life, loss of limb, significant permanent disfigurement. So that could be, a facial deformity because of injuries such as a shotgun blast to the face and so on. Or there's risk for significant permanent disability. So think about your patients who suffer a traumatic brain injury. They are at risk for a significant permanent disability. So one of these four items have to result from an injury or trauma. And it has to be caused by blunt or penetrating injury, so auto accident, shooting, stabbing, and so on, or exposure to electromagnetic, chemical, or radioactive energy, so electric shock, chemical burns, radiation exposure. We don't see radiation injuries that often, but it is considered a form of trauma. Or another potential cause could be drowning, suffocation, or strangulation. So think about the hanging patients, the women who are abused and strangled by their partners. Think about the patients who drown. They are, by definition, a type of trauma that requires transport to a trauma facility. And the last is a deficit or excess of heat. So excess of heat, we think of, thermal burns. But think about the patients. Wintertime is coming. You find a 90-year-old man wandering outside in his underwear. You suspect he is hypothermic. That patient is at risk for loss of life, could lose a limb or result in permanent disability because they've got frostbite injury to their toes that may require an amputation, and they were exposed to a deficit of heat. So hypothermic patients could meet the state definition for trauma and require transport to a trauma facility. This is the algorithm that has been used and published by the State Division of EMS recently in the past couple of years to break down the rules to a better understanding. If you look at what's been out there in the past, they've had lists and so on that are really kind of hard to follow. So this really is the best graphic representation of what the rules require. And, it first starts at the top with what we would in the past call, physiologic indicators. And then on the right midsection of the algorithm, you have the anatomy or anatomic indicators and the special circumstances at the bottom. So I'm going to work through this over the next couple slides. But, if we start at the top, we've got those physiologic indicators, and it's based upon level of consciousness and vital signs. I'd like to point out, providers in the past have asked, okay, what's a pediatric trauma? When do the patients have to go to a pediatric facility versus an adult trauma patient? And here it spells it out for you. Patients age 16 to 69 are considered adult. That doesn't mean it's wrong to take a 17-year-old patient to children's, but generally at an adult trauma facility should be able to handle patients age 16 and up. So pediatric patients are defined as ages 0 to 15. There's an indication to go to the trauma center if their GCS is less than 13. If they don't localize pain, you're talking about a young child who's not able to communicate. If they have an altered level of consciousness, if they've had LOC for more than 5 minutes, if they have episode or evidence of respiratory failure or poor perfusion, or for a child under age 1 if the respiratory rate's less than 20. Adults are very similar with some different parameters. I like to point out that for an adult versus a geriatric patient, the systolic blood pressure for an adult is less than 90, goes to a trauma facility. For a geriatric population, it's less than 100. And for an adult versus geriatric patients, a geriatric patient with a GCS of 14 or less with evidence of a head injury goes to a trauma facility, is considered a trauma patient. That's a little more stringent than what's expected of an adult. But we know that geriatric patients don't bounce, don't recover, don't do as well after sustaining trauma. So the geriatric trauma triage criteria are more conservative. So these are the physiologic criteria, and I try to keep things simple. I look for the first indicator the patient fails. If the patient fails on that indicator, they're a trauma patient. So if their GCS is 12, I know they need to go to a trauma center. Doesn't mean I ignore the other things that are part of the assessment. It means my destination has been decided for me. Pay attention to geriatric versus adult, and I will point out some additional areas on additional slides.
Yeah, great job on this slide. There are a lot of similarities in these three categories, and Dr. Zeeb does a great job of highlighting those finer points between adults and geriatrics. And I can't stress enough that the older we get, the less tolerant our bodies become in adapting to stress. Having said that, we as providers should have a higher threshold for concern, and that's reflected in those thresholds for systolic blood pressure and GCS, as you've seen here. There are pitfalls, however, and in regards to systolic blood pressure, bear in mind that many elderly patients may have multiple comorbidities or maybe are on antihypertensive medications that may result in them being chronically hypotensive. As for GCS, many elderly patients may also have dementia, which can often be misinterpreted with a lower GCS. So it's really important to know from those at the scene what comorbidities and medications a patient may be on, as well as if their mentation is at baseline or is it an acute change from baseline. This type of information is all considered high value information by our trauma team when doing our initial assessment in the trauma bay.
Here to all ages. So anybody who's got penetrating injury to the head, neck, or torso is considered a candidate for trauma facility. Significant crush injuries of the head, neck, or torso. Any evidence of flail chest, any significant abdominal findings, beware the seatbelt sign. I, on occasion, see patients who are brought in as non-trauma alerts. The patient's been in an auto accident. We open up the pants and there's a seatbelt sign, not recognized via EMS because EMS didn't look. If you have a patient in an auto accident with a seatbelt and there's significant damage to the vehicle, take a look in the suprapubic area, see if there's any evidence of a seatbelt sign. Evidence of pelvic fractures, spinal cord injuries, or suspected spinal cord injuries need to go to a trauma facility. Any penetrating injury proximal to the elbow or knee, any amputation proximal to the wrist or ankle, crush of the arms or legs, two humerus or femur fractures, so 2 or more long bone fractures for adults and children. Go to a trauma facility. I like to point out at the bottom, if you have a geriatric patient with a long bone fracture as a single long bone fracture as a consequence of an auto accident, they have met the criteria for trauma facility. Anything second or third burns greater than 10% of total body surface area goes to a trauma facility. I would be very conservative in terms of transporting burn patients who have significant facial or genital burns. Regardless of how much surface area it is, I would seriously consider taking them to a trauma facility direct or a burn facility directly. Open skull fractures, and then drownings, near drownings, and strangulation. Anything with asphyxia defined as trauma, it should go to a trauma center. We're trying to get away from the word near drowning. Any patient who's been in the water and has suffered as a consequence of whether they've survived or not, that I would consider them traumas. And then finally, if you look at anatomic, any geriatric patient with or injuries in 2 or more body regions should go to a trauma facility. So if it's a chest injury and a femur injury, they would automatically qualify for transport to a trauma facility.
Yes, so there are 6 body regions, and they are number 1, the brain; number 2, the head, neck, and face, which we lump together; number 3, the chest; number 4, abdomen and pelvis; number 5, the spine, any part of it; and number 6, the extremities. If a geriatric patient has 2 or more body regions injured, we will definitely evaluate them in the ED. This is not to say, though, that they will all be trauma alert activations. These will be discussed later in this podcast. Remember, these are just selection criteria to help you decide if one of your patients would benefit from a trauma center evaluation.
The algorithm also identifies special circumstances. These are things to consider, but they're not absolutes. They are not in themselves a reason to go to a trauma facility. Something for you to consider as an EMS provider. These are the patients where you look at them and go, I can't believe they survived that accident. They physiologically, anatomically look okay, but your gut says something's not right. So falls over 20 feet, for children over 10 feet or any height 2 or 3 times greater than their own height. Any motorcycle crash over 20 miles per hour. Think about those high risk auto crashes such as ejection or death in the same compartment. Think about those vehicles that have OnStar or other vehicle telemetry data devices. If OnStar says this accident or the mechanics of this accident are such to suggest high risk of injury, those patients should be transported to a trauma facility. And actually, I think that's more of a absolute than even just your gestalt or special circumstances. Any auto versus pedestrian or bicycle thrown, run over, or the vehicle's going over 20 miles per hour. If you look at the geriatric populations, if you have a geriatric hit by a car, that's an automatic trauma patient for a trauma facility. Think about the comorbid conditions. Pregnancy is an important consideration, not just in terms of this patient may benefit from going to a trauma facility versus a non-trauma facility, but in terms of your destinations. Nationwide Children's Hospital does not have the ability to provide care for pregnant teenagers regardless of the age. So if you have a 13 or 14-year-old who is known to be pregnant or is obviously pregnant, they should go to an adult trauma facility, and all of our adult trauma facilities in Franklin County have obstetrical services available. Have a low level sufficient for patients with bleeding disorders or particularly anticoagulants. It seems like everybody over age 60 or 70 is on one form of anticoagulant or another. Have a very low level of suspicion for these patients, particularly if they have evidence of any kind of a head injury. At our facilities, if the patient comes in, they're on anticoagulants, any type of head injury, we have a very low threshold for a CT of the brain, because these patients can easily develop a subdural hematoma or other complications of that injury. Also think about patients who are on dialysis or diabetics, or any patient with a compromised immune system, such as patients who are currently on immunotherapy or chemotherapy for cancer, or chronic suppressive therapy because they've had a heart transplant, liver transplant, or renal transplant. I would consider those special considerations to transport patients to a trauma facility. Let's spend a little bit more time talking about geriatric trauma. Again, this is age 70 and up, so I'm not quite there yet. Any geriatric patient with a GCS of 14 or less with known or suspected TBI, this is 1 point higher than for the general adult population. Fall from any height with evidence of head injury, so including standing. they meet criteria. So if you have grandma in the kitchen, she falls down and hits her head, she should definitely go to a trauma facility based on the criteria. Any patient with a systolic blood pressure less than 100 in the geriatric population. Here's another change from the adult population. Any patient 70 and up with a single long bone fracture from an MVC. For adults, remember, it's two long bones, so femurs and humeri. And any geriatric patient who's struck by a car, regardless of speed. Those patients should go to a trauma facility based on the state criteria. And then at the bottom, I also bring up, how about that anticoagulated patient? What are you going to do with him or her?
So this is a great question. Anticoagulant choices have really increased over the last 2 decades. As one might have guessed, the incidence of oral anticoagulant use in the general population has increased from about 8 to 12% in 2013 to 2017. But if you just consider the nursing home population, this percentage has increased from 41 to 58% during that same period. So what if folks are on a blood thinner? Are they even therapeutic to cause concern? Generally, patients achieve a therapeutic range of about 72 to 75% of the time. Those that don't actually achieve that therapeutic range are usually found to be subtherapeutic as opposed to supratherapeutic. So getting back to the question, how about an anticoagulated patient? There are about 29,000 ED visits for bleeding complications of warfarin, otherwise known as Coumadin, and over 10,000 warfarin-associated intracranial hemorrhages in the U.S. each year, at least based on a 2011 study. And regarding trauma patients, 9.3% of warfarin users died compared to 4.8% of non-users. So if you are a trauma patient and you are on warfarin, you have a 2 times greater risk of dying. Given all this, I think you have to err on the side that these trauma patients are at a therapeutic level and have a significant risk of injury that could become life-threatening if undiagnosed. See, as we age, our brains tend to shrink within the confines of the skull. And if you have an intracranial hemorrhage and are on blood thinners, it will usually take longer for the bleeding to become a space-occupying lesion causing shifting of brain structures. And as a result, there may be a delay in seeing acute changes in mentation. So patients may seem okay in the field, but as the bleeding ensues, the acute mentation changes may not be seen until they show up at the hospital or even within the first 24 hours of inpatient hospitalization.
For peds, the big discriminators are evidence of poor perfusion, evidence of respiratory distress, and any child with a respiratory rate less than 20 if they're under 1 year of age. So these are pretty straightforward. Your gestalt should be able to tell you this kid's in trouble. This child needs to go to nationwide. On this slide, this is kind of the list of everything we've talked about that is from an old COTS document. The criteria are correct. It's just, I think, harder to understand than the algorithm that we looked at toward the beginning of the conversation. Again, in terms of mechanism of injury, in general, can be considered for making a destination decision, but in itself is not an absolute indicator per the trauma triage rules for you to transport to a trauma center. This is where your gestalt goes into play. This patient doesn't look right. My gut says something's wrong with this patient, even though they don't hit the specific criteria. If your gestalt says they're not right, I would take them to the trauma facility. And again, the indicator for geriatric pedestrian struck or fall is important as a mechanism of injury for the geriatric population. There are 5 exceptions that are outlined in Ohio Revised Code where you do not need to transport a patient to a trauma facility. The first is it's medically necessary to transport the victim to another hospital for initial assessment and stabilization before transfer to an adult or pediatric trauma center. So this is, for me, particularly important in the outlying areas where the patient, it's a good 45 minutes to get to a trauma center. Transporting to the closer facility may be appropriate for stabilization because they need an airway, they may need a transfusion, they may need management of their tension pneumothorax. But it's also, I think, something to think about even within Franklin County, where it's snowing outside. You've got 4 inches on the road and another 3 inches coming. Your transport times may be such that it be in the patient's best interest for patients to go to the closest hospital for stabilization with transport to a trauma facility as they become stabilized. For this, I think about a patient we had at Mount Carmel East before it was a trauma center. The patient was in an auto accident 1.5 miles from Mount Carmel East, and still it took EMS 30 minutes to get to East because of the snow and the weather. That was a good example of a patient who was stabilized and transferred after they were stabilized. Second is it's unsafe or medically inappropriate to transport the victim to an adult trauma center due to weather conditions. I kind of alluded to that as a part for A, but again, it's patient needs stabilization because the travel times to a trauma facility is just too long. Another option or reason, and I see this for many of our outlying trucks, is transporting the victim to adult or pediatric trauma center would cause a shortage of local EMS resources. So can your department afford to take their truck out of service for 2 hours to get the patient to Columbus to a trauma facility versus to a closer local hospital where they can be stabilized, then either transported by ground vehicle or helicopter? Or no appropriate adult or pediatric trauma center is able to receive and provide care for an adult or pediatric trauma patient without undue delay. So if you think about our current circumstance in Central Ohio, hospitals are having staffing shortages and are on divert status. But keep in mind, none of our specialty hospitals will divert critically ill patients. So if you have a trauma patient, the closest trauma facility will accept those patients. We are not at the point where we are totally unable to provide care for these patients. And the last thing is, before transport begins, the patient requests to be taken to a hospital that's not a trauma center, or if it's a child less than 18 years of age, the request is made by an adult member of the patient's family or legal representative. So the key points here is that the patient has to make the request before the truck starts to move. I would also suggest that the patient has the capacity to make an informed decision. If the patient has a TBI and is hemodynamically unstable, I would doubt they have the ability to make an informed decision and make such a request. That's a decision you're going to have to make with them in the truck.
So, in regard to where patients should go, several years ago I pitched the idea at COTS regarding pre-designated regionalization of trauma care. That is, if a patient is injured in a certain region of Columbus, they should be pre-designated to go to a specific trauma center based on proximity. It makes good intuitive sense. Successful trauma care is largely time sensitive. Shortening that time from injury to definitive care is expected to produce better outcomes. One foundational study in trauma regionalization done over 30 years ago found that simply regionalizing care reduced preventable deaths from 14% to 3%, and also reduced the delivery of suboptimal care from 32% to 4.5%. In reality, proximity generally ranks supreme over the institution, be it OSU, Grant, Mount Carmel, or Riverside, which honestly actually says a lot about the quality of trauma care we're delivering here in Columbus. Remember, it's not about the individual trauma centers. It's about the network of provisions that we collectively provide for this and neighboring cities.
Also, I'd like to point out some special considerations that have been reviewed by local trauma surgeons and trauma centers. This is through COTS. All of these are within the rules, the state trauma triage rules. First is, again, trauma patients less than 16 go to Nationwide Children's, unless they're pregnant, in which case they should go to the closest adult trauma facility because they are pregnant and need the consultative services of obstetrician. Burn patients go to OSU and to Nationwide. I've had some questions about, if the patients had a significant potential exposure to carbon monoxide, should they go to OSU regardless of age so that they can be placed in their hyperbaric chamber? I've talked with Dr. Stoner about that from Children's, and his comment is, if you have a burn patient, take them to Children's because the burn injury is a greater risk to them than the carbon monoxide exposure. So they will treat that child at Children's. Don't take a pediatric child to Ohio State thinking that they need to be dived in the chamber. Isolated eye injuries go to Ohio Health Grant, Mount Carmel East, or Ohio State Wexner. Upper extremity amputations, particularly with the hand, should go to microvascular centers, which include Grant, Riverside, OSU, and Nationwide Children's. Mass casualty events are addressed by specific surge plans and regional guidelines in terms of what do we do with mass casualty situations with large volumes of trauma patients. And then finally, hemophilia patients should go to the OSU or Nationwide Children's. We do not have a lot of hemophilia patients in our area, but we have them. And this is hemophilia. These are patients who have a diagnosis of hemophilia. These are not patients who are anticoagulated. Standard anticoagulation can be managed at any of the adult or pediatric trauma facilities. Just a couple of slides about trauma centers. The category of trauma is not the same as the level of certification as a trauma center. So category 1 patients do not have to go just to a level 1 trauma facility, and category 2 patients don't necessarily go to a level 2 trauma center. Categories of trauma are used by hospitals to allocate resources on patient arrival. So a category 1 patient is a more severely injured patient. More people will be present in the resuscitation bay and the trauma bay on EMS arrival. Category 2 patients still have significant injury, but they are not as critically injured as the category 1s, and they have less of a staff response on arrival in the trauma facilities. And trauma designation, level 1, level 2, level 3, level 4, that is via the American College of Surgeons, and they determine which facilities meet which level of certification.
That's exactly right. To provide some historical context to this, the ACS, or American College of Surgeons, states that trauma centers must allocate resources appropriately for full versus partial activations. So in the early 1990s, when hospitals in Columbus were preparing to become trauma centers, we made the mistake, for lack of a better term, of calling our activations level 1 versus level 2 rather than using the ACS recommended nomenclature of full versus partial. This led to the inconvenient deception that level 1 trauma alerts should go to level 1 trauma centers. The fact is that all ACS verified trauma centers are capable of accepting all degrees of injury and performing the initial evaluation and stabilization of the injured patient. So to correct this, we all now refer trauma alert activations as category 1 versus category 2. As for trauma designation, the ACS doesn't provide trauma center designation, and rather, the ACS routinely inspects a hospital's trauma program through a grueling, comprehensive process and verifies that a hospital's trauma program is in compliance with national trauma standards to allow the state then to designate a hospital as a trauma center.
Trauma centers are certified by ACS, Committee on Trauma. It's a 3-year process. Level 1s are expected to manage the most severely injured. Level 2s are expected to provide the same level of clinical care as a level 1, but they have less stringent standards for critical care oversight, typically have lower volume, and have no requirement for publishing. Publishing research is a significant part of discriminating between a level 1 and a level 2 facility. A level 3 facility initially manages trauma patients with transfer of the most severely injured, and level 4 patients provide initial evaluation and assessment, with most patients being transferred to a higher level of trauma care. Just a source of illustration in terms of categories of trauma, again, categories do not also equate to level of certification by American College of Surgeons, but it indicates the amount of hospital resources allocated to provide patient care on the patient's arrival. So the most severely injured are category 1, the less severely injured are category 2. You may also hear about trauma consults. These are patients that have injuries, may require admission, but are stable. Within the Mount Carmel system, I know most trauma consults, if not all of them, come in as a referral from another emergency department where they've initially been assessed, identified to have a traumatic injury requiring transfer and admission, but the patients are relatively stable and do not need a category 1 or category 2 response on arrival. On the right-hand side is something I pulled out of the American College of Surgeons Orange Book on trauma centers, and it's just basically, kind of a full trauma alert criteria on the left. That would be our category ones, or limited trauma response on the right, which would be the category twos. So, patients who meet some of the requirements for transfer to a trauma facility but are not as severely injured would be a category two. I think the one thing I would like to point out is EMS provider judgment is an important indicator, particularly for category twos. These may be the patients who physiologically and anatomically don't fit any specific criteria, but your gestalt, your impression is that there's something not right about this patient, or I'm amazed this patient survived this auto accident. They rolled 3 times down a hill and it was a half-hour extrication. Those patients, just your gestalt, probably going to say they need to be seen at a trauma facility. So in summary, patients who meet Ohio Trauma Triage guidelines are transported to the closest, which means shortest transport time, level 1 or level 2 trauma center, unless one or more of the permanent or permitted exclusions are met, such as weather, need for stabilization, and so on. For non-Franklin County MEC EMS members, if there's a difference in travel time to a trauma center versus local ED, if it's not that great, transport that patient to a trauma center. There's really no definition of how much time that should be. I think that's locally determined in part by how much of a stress on your local resources would occur if you took your one truck out of service to go to the trauma center versus the closest hospital. And if the closest hospital is a non-trauma center and one or more of the allowed exceptions is met, you can take the patient to the closest hospital or the hospital the patient's request. Finally, I think I'm a bit skeptic about helicopters, but you can use a helicopter if it makes sense. It'll make a difference in patient outcome. For me, a lot of benefits of helicopters are lost in our service area because of the need to rendezvous with the helicopter, offload the patient from the ambulance to the helicopter, and then fly them to a hospital. So have some sense, generally from my perspective, if you get to a trauma facility in 30 minutes by ground, helicopters are not going to add any substantial benefit unless there's extenuating circumstances such as protracted or prolonged extrication times, and the helicopter's on the ground there waiting for the patient. Thank you. I appreciate it. I'll let Dr. Dizon throw his comments in. Our topic for next month is going to be the 2022 protocol review. So I look forward to talking to you then. Thank you.
Not a whole lot to add here. Dr. Zeeb has done a really nice job of summarizing the Ohio Trauma Triage guidelines, and unless an injured patient meets one or more of the permitted exclusions, they really need to be evaluated at a trauma center. Which center? I can't stress enough that successful trauma care is largely time sensitive. Shortening that time from injury to definitive care produces better outcomes in terms of preventable deaths and reduced suboptimal care. As I've said earlier in this program, proximity generally ranks supreme. We are really blessed to have a network of truly outstanding trauma care, so no matter where you're injured in Columbus, you will get great care. Thanks, Dr. Zeeb, for inviting me to participate, and I'm looking forward to our next talk. Until then, be safe and happy holidays.